So what makes me so passionate about stroke that I'm here talking to you this afternoon? And I'd probably say it starts with an early fascination with the human brain. And that led me to neurology. And then during my residency, I learned more and more about stroke. And I saw how devastating it could be. But I also saw that there were treatments that we had where we could minimize or potentially even completely reverse that devastation. And that's what led me to pursue a career in vascular neurology. So, first of all, what is stroke? First, one of the most important things to know is it's very common. So 1 in 6 people in the US will be affected by a stroke. We have almost 800,000 strokes per year. And currently it's the 5th leading cause of death in our country. It's also very costly, and part of that is because it's the #1 cause of long-term disability. So not only is there a cost associated with when the patients have their initial stroke, there's the hospitalization, acute treatment, but then it's the years lost of someone who was before a productive member of society and now is disabled and not able to function the way they were before. So it's very costly. It costs our country about $70 billion a year, and those numbers just continue to rise. What causes a stroke? Well, it's really lack of blood flow. There's 2 different types of stroke. One would be what we call an ischemic stroke, where there's a blocked blood vessel. That's about 85% of strokes. And you can see that in the top right. And then there's another type of stroke called a hemorrhagic stroke. That's where you have bleeding into the brain. So the blood vessel ruptures. Again, it's lack of blood flow beyond that point. That brain tissue then is starved of oxygen. And so I have up here 2 million neurons. And I have that up there is because every minute that goes by of a stroke, you're losing 2 million brain cells. And so it's really a race against time. So when we talk in the stroke world, we oftentimes say time is brain. And that's specifically because of that. And so the overall goal that we have when we're dealing with somebody who's having an acute stroke is to restore that blood flow as soon as possible. So really, as I mentioned, it's a race against time. It can be a difficult diagnosis to make, though, which is one of the main things that we have to deal with. Right now, it's the 4th most common misdiagnosis. And there's about 100,000 patients that come in with a stroke into an emergency department in the US per year where the stroke is missed initially. This brings in the idea of stroke neurologists. And so this is somebody who's trained in neurology and then further trained in stroke neurology. And what we're able to do is help with the overall diagnosis of stroke, help with the treatment decisions, as well as where we go from there. So as I mentioned, the differential diagnosis, so this is what could possibly be happening to this patient as they come in, is quite extensive for stroke. Let's see here. And these are all things that could look like a stroke, so things like migraine headaches, seizures, tumors, abscesses. You can see the list kind of keeps going, and these are all things that somebody who's coming in with acute neurologic symptoms, it might be one of these entities, or it could be an acute stroke. So what we really need to do is make that diagnosis, but again, we're trying to make it as soon as possible, because certainly we have treatments available, which I'll talk about a little bit, but some are, they can certainly have a negative impact on a patient as well, and so we want to make sure that we're doing the right treatment to the right patient. So one of the first tools that we have, this is called IVTPA. So it's a clot-busting medicine, basically. And what it does is it's injected through the IV. And what we can do with this medication is if we're able to treat somebody quick enough, so typically we have up to about 4.5 hours to treat these patients, it can break up that blood clot and restore blood flow. This, as I mentioned though, given the fact that it's a clot-busting medication, it can also have a significant side effect of bleeding. And so as I mentioned, 15% of stroke patients might have a hemorrhagic stroke, and certainly it would be catastrophic to give this medication to one of those patients. So we need to do some diagnostic workup and then make sure that we're dealing with the right patients before we give the medication. If we can give it, it can certainly have a positive impact on the patients. Another tool that we have is something called mechanical thrombectomy. So about 10% of our ischemic stroke patients have a very large blood
balloon
clot.
guide catheter as close to the thrombus site as possible.
And when the clot is so big that the TPA might not be enough to dissolve the clot, we can use this procedure. And as you can see here is where a catheter is entered typically through the groin, up through the blood vessels, up into the brain to where the clot actually is. Once it's there, then a stent can be deployed. or sometimes there's suction devices. We have various devices that we can use. But when we're able to deploy a stent within that artery, then it will restore blood flow. After that blood flow is restored, then the stent, actually the blood clot is incorporated into the walls of the stent. And after so here we see the stent being deployed. After the blood clot then is incorporated in the walls of the stent, then the whole thing can be removed and prevent that further on distal brain tissue from becoming a complete stroke. So we know also this is something we've had the ability to do this for many years, but just in 2015 was the first time we had any true evidence in the literature that we can really help patients with this. And again, it's about 10% of patients, but these are the patients who are potentially going to be the most devastated because it's one of the major blood vessels in the brain that's blocked. So by having the ability to do this procedure, we can really have a positive impact on those patients who are, like I said, are the most likelihood of having a major disability. So these are just pictures of, again, with the stent with the blood clot in it and what's actually removed from those blood vessels in the brain. Like I said, it's incredible technology that we have between the TPA medication and then the mechanical thrombectomy. We know that we do improve outcomes with these various therapies that we have. With just to give you kind of a general idea, a sense about how impressive it is, what we call, in statistics, there's a number needed to treat. So it's the number of patients that we need to treat with a specific medication or device to improve outcomes, and that number is 4 for these therapies. Whereas if you think about somebody who's having a heart attack and there's the big rush to get everybody treated, the number that needs to treat for thrombolysis in patients that are having heart attacks are somewhere more in the 20s. So this is really remarkable therapy. It's something that's great that we have, but there's a sobering reality, and that's, right now we're at about a 5% treatment rate. Number's gone up a little bit, but this is still right around where we are on a national basis. So 5% of patients who are coming in with stroke are being treated. So what do we have, and why is that the case? Part of it is due to the fact that there's a significant chain of events that needs to occur to get these patients treated. So first of all, they need to recognize that they're having a stroke. A lot of patients have weakness, numbness, tingling, and think, well, I'll see, maybe I can shake it off, maybe it'll just go away, and they don't call 911 right away. And so that's the first thing that needs to happen. Then the patients need to be transported to an emergency department. If we have pre-notification where those EMS providers are calling the ER and letting them know that this patient is coming in, that's very helpful, because what the ED team needs to do is be ready for that patient's arrival so that they can get them to the CAT scan right away. That's the important part to rule out that hemorrhagic stroke patient and maybe some of those other mimics that I showed you, as well as do some lab works, et cetera. Then the last 4 that I show you are in a little bit of bolded, because those have to do more with where the neurologist's role is. And so that's doing the detailed neurologic exam, helping make that diagnosis of if it's a stroke or not, and then making a decision, is this a patient who could benefit from TPA, or are they a patient who might also benefit from endovascular therapy? Like I showed you, we have different ways of treating these patients. Sometimes they need more advanced imaging, like a CT angiogram. And then finally, we'd have to notify the endovascular team, who would then mobilize. So a lot of different things need to occur to have all of this happen. A big problem, like I showed you those last 4, are that it has to do with the neurologists. And neurologists typically aren't in an emergency department, especially in the community. They're in private practice. They might be in their office, seeing patients there. If it's in the middle of the night, again, they're not in the hospital. They're at home. And so the neurologist then is driving in to see that patient, and that's taking valuable time. Like I said, every minute that goes by is essential. So what do we have now? We have telestroke. This has been something we've been doing for about 6 years now here in Chicago. And what it really is doing is it's bringing the neurologist to the bedside, and it doesn't matter where the neurologist is. What we're able to do is we have robots in emergency rooms throughout the Chicagoland area. And this is something that's done internationally as well. And what we're able to do is evaluate that patient and really be at the bedside within minutes rather than waiting to drive in or simply trying to do this over the telephone, where it really makes a huge benefit to be able to see the patient, examine them remotely, talk to them, talk to their family, help make that decision. And just to give you an idea, just over the past 6 years, over 500 patients have been treated with IV TPA in the Chicagoland area alone. So we're making a huge impact on these patients' lives. And again, these are patients who were otherwise were at emergency rooms where really not a lot of TPA was given, again, because of all those other challenges. So, I was trying to think, all right, well, what's next? We've done a great job with Telestroke, and we're treating a lot of patients throughout the Chicagoland area and nationally, internationally. There's many Telestroke programs out there. And a lot of the focus that we've had has been on something called door-to-needle time. So the door is when the patient arrives in the emergency department until the needle time, which is when they're getting that TPA. And there's huge efforts to decrease that door-to-needle time. And so that's getting that CT done right away, getting the neurologist involved right away, labs drawn, et cetera. And some of our door-to-needle times have gone down from averages of over an hour, hour and a half, and sometimes now we're even treating patients within 20 minutes, which after you see all those things that need to happen, it's pretty impressive. But then we have to look beyond that, right? So what's really happening before that patient gets to the emergency department? So we start looking at the onset to treatment time. So from the door-to-needle time now to onset to treatment. And really that's where we are starting to focus now a little bit more is, what's happening before they get to the ED. And this has led to the concept of a mobile stroke unit. So mobile stroke units, the first ones were in Europe under 10 years ago, and now in 2014 was the first one in the United States. And what makes a mobile stroke unit different than a typical ambulance, there's a few things, but basically what will happen is if somebody has stroke-like symptoms, the local EMS is going to be sent out to dispatch to that site of where the patient is, but the mobile stroke unit is going to go at the same time. And what the mobile stroke unit can do is, if you see in the bottom left, there's a CT scanner on board the ambulance. And so we're able to determine if this is a hemorrhagic stroke or an ischemic stroke patient right away. And this is basically like in the patient's driveway, outside their home, in the street. The mobile stroke units are also equipped with telemedicine equipment. So you saw what we have out in the emergency rooms in the community. This will have the same thing. So you'll have the stroke neurologist able to see the patient. You've got the CT scan done, and we'll have the TPA right on board. So we're giving the clot busting medicine, again, in the patient's driveway. We've been able to cut down, early data shows cutting down the treatment times by at least a half an hour. And it might not seem like a lot, but if you remember, every minute that goes by, it's 2 million neurons, right? So it's major differences that we can make as far as, again, improving patients' outcomes. Besides the TPA, we're also going to be able to improve our triage. So currently, again, patients might go to a community hospital emergency room, go through that whole process of getting the TPA, but then we realize this is somebody who has a large vessel occlusion as well. And now we need to transfer them to a comprehensive stroke center because that second therapy, that endovascular therapy, is really only done at major medical centers. And so now you're talking about putting that patient in another ambulance and transporting them. Those transport times can often, from when they arrive in the first ER until they're at the destination where they need to be, can sometimes be up to 2 hours. So you can imagine that if we're able to perform all this, get the TPA going, make the diagnosis in the ambulance, we're going directly to where they need to be. So really what we're talking about is really having the right person in the right place at the right time. So the right person meaning that patient who's having a stroke, that we've confirmed the stroke, possibly with a large vessel occlusion, get into the right place, so a primary stroke center or a comprehensive stroke center where we're able to provide the definitive care, and then at the right time, and the right time is as fast as possible. And if we're able to do all of this and continue, we're really going to have a major impact in our fight against stroke. Thank you.